day in Cincinnati. I hope where you are, it's also a beautiful day. I am thrilled today to be joined by Dr. Holly Pederson from the Cleveland Clinic, and I will introduce her a little bit more in a second. But as usual, I'm going to quickly run through our COVID statistics. And I will tell you, remember that going forward, instead of doing Facebook Live every day, I'm only going to do it Mondays and Fridays, except when I have special guests with me. All right, so last time we talked about numbers was Friday. Today, globally, we're at 3.56 million cases and 250,000 deaths globally. The US has increased to 1.18 million. And again, remember, that's in comparison to Italy at 211, Spain at 217, France at 169, and the UK has jumped ahead at 191. So we are well ahead of all of the European countries combined. And you realize, of course, we've been talking about this every day, that our testing is so inadequate that our numbers are vastly higher than that. When we switch to the US and we talk about where we are in New York, we are at 318,000 positive cases. And we've been talking about the inadequacy of testing. And I will tell you, New York is a great example of this. So even though out of the, and we'll get to the 7 million tests we've now done in the United States, New York has 1 million of them. But remember, we've been talking about percentages. So if they've done 1 million tests and 318,000 of them have been positive, that's a 33% positive rate, which tells you, again, we are only testing the sickest of the sick. And we are just, testing has not improved over the 8 weeks of this substantially. New York deaths are at 19,000. New York City is 170,000. So as it's been the whole time, more than half of the cases in New York. And the New York City deaths are 13,000. In New Jersey, we're at 129, which is the next closest state. Massachusetts at 66, Michigan at 43,000. Ohio has just crossed 20,000. We are just above 1,000 deaths. We have almost 4,000 people who have been hospitalized and 1,090 in the ICU. So again, our numbers have been running really pretty consistent in terms of percentages of people out of that 20,000 with 1,090 in the ICU. It's right around that percentage we've been talking to the whole time of about 5%. The US testing is 7.1 million. So that is up. On Friday, it was 6.3 million. So again, I think it's ramping up, but at least as far as I could research, the testing is not happening in hotbeds like New York. I don't think they've been able to scale their testing substantially. So it is happening in other states. And I know California has really been increasing testing, and their percentage is actually lower. In our state, we have done 150,000 tests, 20,000 of them have been positive. So that's a positivity rate of 13.3. So certainly better than New York, but not nearly where it needs to be, which is, we would like that well under 10% to suggest that we are appropriately testing. So across the states in the US, we're all starting to go back to gradual re-entry. And I think it remains to be seen what impact that has quickly on our numbers and what's going on. I know everybody on this beautiful spring day here today in Cincinnati is anxious to go back to normal, but I think that we're probably still a way off. So instead of talking about testing today, I am really honored to have a really good friend of mine and colleague, Dr. Holly Pederson, with us today. She is Director of Medical Breast Services at the Cleveland Clinic and Professor of Medicine at the Cleveland Clinic. And I thought today, to try to talk about anything other than COVID, we would really go back and focus on breast health and breast cancer risk assessment and high risk genetics of breast cancer, and let Dr. Pederson talk to us about what she does at the Cleveland Clinic, and then take questions from all of you. So Dr. Pederson, thank you so much for joining us today.
Oh, thank you so much for having me. And, you know, these are unprecedented times. I hope that all of you that are listening are healthy and comfortable and safe. I don't know what the new normal is going to look like. We all are hoping for it to go back to normal, but I don't know what that's going to be. So I've been at Cleveland Clinic since 1997. I'm an internist by training, like Lisa, and I've just done breast health and breast disease since 1997. I run what's called the Medical Breast Program. It's everything non-surgical about breast disease. And the majority of breast complaints and breast issues really are non-surgical. You know, many times you'll have a symptom or a problem and you go in and it's not breast cancer, but it should be checked out, you know, and what about screening and what about breast density and should I be getting this and should I be getting that? There's all sorts of questions. What about my family history? I'm concerned that I might be at high risk. You know, we get a lot of patients who want to know about their risks and their options. And then we have a program for long-term survivorship care beyond the first 5 years of treatment, when they're ordinarily followed by medical oncology. We help out after that and address issues like bone health and sexuality and cardiovascular risk reduction. So that's what I do. I'm largely clinical. I do some clinical research and some writing and speaking. But patient care is really what I enjoy the most.
And lots of education of physicians. You do that too. You are just rock star in that capacity, and many of us are very grateful for all of your education. So,
thank you.
So
that is a passion.
What's been the toughest transition for your patients, do you think, during this time? How's it gone with COVID and converting a little bit to telemedicine?
Well, you know, we went from 0 to 60 in 0.8 seconds with regard to virtual health. We had talked about virtual health and online risk assessments, but it really wasn't until COVID hit that overnight, you know, people were advised to stay home, and we learned how to use virtual platforms to speak with our patients. And I think it's really gone very well. You know, it's an entirely different kind of encounter with a patient, talking on the phone or talking virtually. It's much better when you at least have a face-to-face. And in some ways, it's more private and more personal. It doesn't seem like that would be the case, but that's what I've found, and I think some of my patients have found that we actually can get to a deeper level virtually over a longer period of actual interactive time without the rooming time and the waiting time and the rushing around time. You know, it's a nice time. So the biggest change is virtual visits. I'm sure that's the case with you too.
For sure. It's amazing what you can adapt to quickly when you're forced into it and you don't have a choice, right? And your patients need you to suddenly figure it out. So I think that's probably been one of the silver linings of the pandemic in terms of allowing opportunities for other types of care delivery models that might make sense in certain circumstances. I mean, I certainly do not think that we can go exclusively to telemedicine, at least for older individuals. My 24-year-old son would tell you telemedicine and virtual visits is just fine. He can do everything from his app. He doesn't need to go to the doctor, but I'm not sure for our patients that that's totally true. But so tell me how patients come to see you to start. Can they self-refer? Do they get referred from other people?
Well, I think first you brought up an interesting point.
How does someone see you?
About who could come for a virtual visit versus an in-person visit. And it's important, obviously, that anyone with a breast complaint, a lump or focal pain or nipple discharge, or my breast looks funny or it's red, you got to come in and be checked. That cannot be done, you know, at all over any sort of telehealth platform. And there are certainly circumstances, especially in young women with dense breasts, where the physical exam is useful in finding things that a mammogram may not pick up. Breast MRIs typically won't miss things that the human hands will find, but on that mammogram visit, it's also important to come in if you can. So how do people find me? You know, I think they find me every which way. I get a lot of patients referred from genetics who carry hereditary predisposition to breast cancer mutations, and I have a lot of patients, over 700 patients that I follow in that group. A lot of patients just with family history who want to know what their risk is. They're referred by their GYN or their primary care provider, but anyone can come to me. Anyone can self-refer. I do largely breast consultations unless people carry a genetic mutation, but I'm happy to like put together a plan for anybody and, you know, answer questions about how they might be screened or what could they do to reduce their risk. It's a very rewarding field.
You do great work. All right. Well, I want to take some questions because it looks like we have a bunch. So can you talk about new genetic testing that will be coming out in the future? My brother had breast cancer, but did not have any of the genetic mutations that are typically associated with breast cancer. Thank you.
Oh, that's a great question. So people should really know what the red flags are for hereditary cancer risk. And having male breast cancer in the family is one of those, what we call red flags. Men very uncommonly get breast cancer. Less than 1% of men get breast cancer in their lifetime. And it is often, but not always, associated with a genetic mutation. Before the fall of 2013, we just checked for BRCA1 and BRCA2 mutations. And BRCA2 is still the most common mutation that's associated with male breast cancer. But in the fall of 2013, we came out with multi-gene panel testing with many different genes that are tested for that predispose not only to breast cancer, but to other cancers as well, and are finding that there are many different genes that can predispose to male breast cancer, PALB2 being one of them, with some interesting recent data in that area. But I would say if your brother was not retested since the fall of 2013, he should return and have that multi-gene panel. But if not, this is also an important point. Patients will often feel like if the testing is negative, then I'm okay. Then there's not a risk factor in the family. But if your brother had breast cancer, even though his test was negative, you should still be followed for high risk and see a specialist.
Absolutely agree. And the question about any testing, new testing coming out in the future, you have any comments about that? It seems that the panel.
Oh, yeah, that's a good question. So, you know, the search is always on for candidate genes. I think that with the recent technology, and recent being over the last, say, 10 years, we've probably identified the majority of highly penetrant and moderately penetrant genes, really high risk and moderate risk genes that are responsible for breast cancer. But the genetic test that's kind of coming to the future is something called the polygenic risk score. There are these little genetic changes called SNPs, and individually they don't confer a lot of risk, but when you combine them all together, you can have a high SNP score or a low SNP score. And that's important for everyone, actually, not only for families that test negative, but for families where no one's had breast cancer, because 75% of the time someone gets breast cancer, they have no risk factors, and you have no idea why they got their breast cancer. And so this SNP profile testing is going to be felt to explain about 14% of additional hereditary risk. So it's exciting stuff.
So
we're going to be doing some more research with that.
I'll actually tell you my story about that. So my breast cancer was just before I turned 50. So I did have genetic testing at that point in time, which was negative, no family history, nothing. And decided just recently to do my SNPs. Now I pretended when I answered my questionnaire to, because once you have breast cancer, you're not supposed to do your SNPs, right? But my presumption was I had to have a bunch of SNPs because I really didn't have anything else. But to your point, it only kind of increases at 14% because actually I had favorable SNPs. I did. So it's not, it's clearly, as we know, it's not 100%. And my hope is, I don't know what you think, that they'll continue to identify more and more SNPs and this polygenic risk score will continue to get better. But at least for me, I was hoping that was going to be really interesting and I was going to understand why I got young breast cancer, but it didn't actually work.
Well, and like Dr. Larkin says, it's not all about genetics. Only about 10 to 15% of breast cancer is truly hereditary, and we don't understand a lot of the rest of it. To be quite honest, we're investigating the microbiome as a possible explanation for predisposition. Sort of what you eat guides the bacteria that are in your body, and those bacteria drive various processes, including cancer predisposition. It's been shown in colon cancer, and we're doing some work in breast cancer, but all the more reason to eat well, exercise regularly, maintain your ideal body weight.
Don't drink too much alcohol. I preach this.
Alcohol,
even though I keep saying
alcohol consumption. And that is, you can tie that back into COVID. A lot of people, are home and are stressed and are drinking more. And this. What we've shown is even light to moderate drinking does increase your breast cancer risk.
Right.
So you need to be aware of that.
So some other questions. What do you think about in-home genetic testing like 23andMe or others to detect for BRCA mutations?
Oh, that's one of my favorite topics. So 23andMe is so well marketed, and nearly everyone has had 23andMe or Ancestry.com. And with 23andMe, it only tests for the 3 mutations that are most commonly seen in the Ashkenazi Jewish community. So if you're not Jewish, it won't help you at all. And if you are Jewish, it's a very, very limited screen that doesn't even really sequence the genes. And so that is it's not the same kind of testing that you get when you come and meet with a genetic counselor and they send off a blood or a sputum sample. It's really important to know. And then people will take their 23andMe or their Ancestry and send it to these third-party interpretation services. And they have about a 40% false positive rate with regard to, findings that aren't even really real. And so anything that comes up positive should be validated. And if you test negative, remember, you still should have a full evaluation if you have a significant family history, because you might want to have multi-gene panel testing. There actually are several companies now that are offering direct-to-consumer multi-gene panel testing that is the real McCoy, the real next generation sequencing. And The two that I know of are Invitae and Color Genomics. But please, Lisa, if you know of any other companies, I don't want to leave anything out, but you can go online and for $250 get the same multi-gene panel test that Lisa had, or that I recommended for the woman whose brother had breast cancer. And that's a real test. That's a real test that doesn't need to be validated.
And the nice thing about those are they have the option to connect with a genetic counselor to help you on the back end interpret your results, because that's one of the things I agree with you about the 23andMe that I've seen, that, you know, again, you can give misinformation. And in fact, I read about a lawsuit of a woman in California, I believe, who had a mastectomy based on a 23andMe test, didn't have it validated, and it was one of those false positives. So again, I think point is be careful with the at-home genetic testing. But I will tell you, the patient who asked, or the person who asked about her brother and her risk, so he had Ambry genetics for 34 genes, the cancer next, 34 genes in 2018. And she's asking about, should she do SNPs for herself given her brother's history?
So that's a great question. And the answer is, we are not sure what the answer to that question is as of yet. SNPs are primarily validated only in the Caucasian population. And so if you're Caucasian, it may be helpful. But you have to ask yourself, what would you do differently? And so Lisa was curious, you know, I think.
Right. I mean, because I'm interested in learning. So again, that's.
But it's not going to, you know, get you a breast MRI. But let's say you had a very unfavorable SNP profile, that you looked like you were at very high risk for breast cancer. You might be more likely to consider taking one of those medications to reduce your risk than you would if you had a very favorable SNP profile. So that's where I think it's going to be the most useful, is in helping patients decide about preventive medication.
And I want to come back to that one too. We'll talk in a second. So I don't have a family history of breast cancer that I'm aware of, but my father and two brothers had prostate cancer at young ages in their 50s with high Gleason scores. Does that make me at high risk for cancer, for breast cancer, I assume she's saying?
So that's a good question. And especially if someone had metastatic prostate cancer, that in and of itself is an indication for genetic testing. Either that or prostate cancer in the setting of Ashkenazi ancestry. You want to actually, in a family, try to test someone who had cancer rather than someone who didn't have cancer. Like the way I like to explain it is, let's say you have 3 children and one has 3 belly buttons, and you want to know if something runs in the family, which child are you going to test? You know, well, you're going to test the one that, you know, that has the abnormality. And so if your father or brothers, particularly the young brothers who had it in their 50s with the high Gleason score, would be willing to go in for genetic testing, that way you could find out if something, you know, is hereditary that might be linked to breast cancer. In and of itself, if their testing is negative, it does not increase your risk for breast cancer.
Great. All right. So let's see if we have any other.
Oh, how much is too much? There you go. You're going to go after the alcohol.
No. Oh, well, yes, go ahead. So that's for prevention too. But go ahead. How much is too much? Because I'm not sure.
Yeah. So, you know, we've all been in that situation where you go over to often an elderly person's home, someone's parents, and they serve you a glass of wine, you know, in one of those like little tiny glasses that, you know, and you're kind of going, this is not a glass of wine. Well, actually, that is a glass of wine. It's we recommend limiting alcohol consumption to less than 7 drinks a week. And, ideally you should have 1 drink a day and 2 days off during the week. But the key is this portion control thing that Americans tend to have trouble with anyways. We know what a beer looks like, a 12-ounce beer, but do we know what an ounce of hard liquor looks like, or 5 to 6 ounces of wine? Well, the way that you sort of look at that is, if no one else is drinking wine in the house and you have a bottle of wine, it should last like 5 days. That's sort of a gauge. And in terms of hard alcohol, like vodka or tequila, typically they'll put 2 to 4 ounces at least in a martini, and the advised limit is 1.5 ounces. So really, you're looking at like 3 tablespoons of hard alcohol, as a quote serving. So alcohol is very interesting. People used to think that the only mechanism by which it increased your risk for breast cancer was that it raised your estrogen levels. But actually, there's a lot of different things that it does. And the metabolites of alcohol are actually probably more toxic than the alcohol itself. And people metabolize these things differently. And so we're going to learn more genomically about who can drink more and who shouldn't drink more, just like with cholesterol. I can eat eggs till the cows come home and I'm not going to raise my cholesterol, whereas someone who's prone to hyperlipidemia has to be more careful. So it's interesting that way.
I 100% agree with your assessment that we are all so genetically diverse that recommendations about anything really, it isn't one size fits all, but that's the way that we've been doing it now without any other ability to do it differently. But I think that in addition to microbiome will be the big breakthrough in the next generation of physicians, that we really are going to have, even like very personalized, right? Even with hormone therapy, right? All the time. Who needs hormone therapy for the benefits of it? And then who are the people that are at risk from it? And I think they're very different. I haven't got to figure that out exactly yet. All right. So
one other thing, though, about alcohol is that remember that 1 glass of red wine a day will reduce your cardiovascular risk. So you can play that out, especially if you're postmenopausal. The other thing that I think is really important is that breast tissue is most susceptible to insult between the time you start your period and the time you have your first baby. And so a lot of this early drinking that girls do and young women do is probably more detrimental than the drinking that occurs later on in life.
So, Dr. Pederson, I want to talk to you about medication for prevention of breast cancer. So I do a lot of risk assessment and, discussion of medication for prevention. And you and I both know that they are way underutilized. And in fact, when I educate the community, and I know you do this as well, which is it's still not in the public lexicon that there are medications to potentially reduce your risk. I mean, people are like deer in headlights when I say that, like they've never heard of those things before. Can you comment on why you think that information isn't more readily available and why there's so little uptake of using medications for prevention when the data is really pretty compelling?
Yeah, that's a great question. So there are 2 medications that are FDA approved for breast cancer risk reduction. And one is tamoxifen, which people are really afraid of because it sounds like a cancer drug. And one is raloxifene or Evista, which you can take when you're postmenopausal. And since women really don't understand their risk fully, they often don't hear about these medications. But tamoxifen in healthy premenopausal women is not associated with any increased risk of serious side effects. And the story goes back to like the 70s and 80s. You know, we noticed that women who had breast cancer had a lower risk of recurrence if they took tamoxifen, but also a lower risk of developing a new cancer on the other side. And so back in the 90s, we took tamoxifen and compared it with placebo in healthy high-risk women. And sure enough, there was a 50% reduction in breast cancer risk. Evista is similar in the postmenopausal setting, and it's also FDA approved for osteoporosis prevention. So in the postmenopausal setting, in meta-analyses, tamoxifen and raloxifene are both associated with about a 1% risk of blood clot, which is the same as birth control pills, and a 1% risk of uterine cancer with tamoxifen. So we tend to use raloxifene. But I think people just don't know about it, and it's not explained to them in a way that they would understand that most women don't have side effects and get through it. And if they take the tamoxifen for 5 years, it protects them 10 to 15 years after they stop taking it.
So this is an area that I'm very passionate about, as I know you are, Dr. Pederson, because this is one of these areas where I also think part of the problem is primary care internists are not comfortable doing the risk assessment parts, so don't actually even start to have the discussion. And it's lots of reasons.
Right.
There's limited visits. They're not comfortable with the meds so much. You know, it's hard to know. But I wish we could get the word out more.
Oh, I know. You just have to excuse me. I'm plugging in my computer.
Oh, you're good. This nice lady, I said that was my last question and I lied. Dr. Larkin, I met with you.
So we've got to get the word out for women to come in and have their risk assessed, because unless you know that you're at increased risk, then you're not, then you wouldn't know about these medications. There's another one that you can take in the postmenopausal setting that doesn't cause blood clot or uterine cancer, called exemestane. It's recommended by ASCO, but it's not FDA approved. I think that they didn't go for FDA approval because the trials were done in Europe, but it reduces your risk by 65%. So, right, good stuff and underutilized.
Right, and the messaging is, if you're a woman who thinks that you have a reason to be at high risk, you should have your risk assessment done and actually understand what your risk is so that you can talk about, we'll get to enhanced screening and medications to lower your risk. So this is from the nice person that asked the previous question. I met with you not long ago to go over my family history. At what point would you recommend talking to someone about SNPs? I know at one point it was in Europe, but not in the US. Would that be the first step before deciding on a prevention drug like tamoxifen? So I'm sorry to tell you that I don't remember your family history well enough, and I would love to go through it with you again and talk about SNPs, because you can get SNPs done now in the United States, either as part of a panel or now independently as well. So you should come back and talk to me if you want to, or maybe go see Dr. Pederson if you want to drive to Cleveland. Dr. Pederson, can you talk about breast density? There's been some messaging in our community that any woman with dense breasts should have a breast MRI in addition to mammography. And my experience is that women confuse fibrocystic breast changes with breast density, and they don't really have an accurate interpretation of they don't know the different categories. And so not all breast density is the same.
Yeah.
We have feelings about that.
So that's a great question. And breast density is something that's determined on the mammogram, typically subjectively by the radiologist. And breast density can range from almost replaced entirely by fat to just a complete whiteout of fibroglandular tissue. And you're kind of born with your breast density. It's very difficult to change your breast density. Tamoxifen can reduce it. Hormone replacement therapy and alcohol might increase it a tiny bit. But you should know your density because you should know what your options are for screening. There are different mammograms that you can choose. I think most people are aware of the digital mammogram, which is very low dose in radiation, but two-dimensional, versus the three-dimensional tomosynthesis type mammogram. And in a woman with anything but fatty replaced breasts, the tomosynthesis actually increases the detection of breast cancers, and so is a quote better test and is covered by most insurance companies. There is a little more radiation, but it's still below the FDA recommended radiation limit. It's still low dose and safe. So what about all these other things? You know, if you screen 1,000 women, you're going to pick up about 4 breast cancers with digital mammography. If you add the tomosynthesis, you pick up an additional 1.5 breast cancers per 1,000 women screened. So it's better, but it's not, you know, a marked increase. If you add screening breast MRI, you pick up an additional 17 to 25 breast cancers per 1,000 women screened. We're actually underdiagnosing breast cancer, not overdiagnosing breast cancer. We want to find it early at its most treatable and curable stage. And not everyone qualifies for their insurance company to pay for breast MRI, and it's very expensive. And so that's been the hurdle. In our area, there at University Hospital, actually not at Cleveland Clinic, there is something called an abbreviated MRI or a fast MRI that's available at a very affordable price out of pocket. We have found, we've looked at whole breast ultrasound. That adds 4 additional breast cancers per 1,000 women screened. So it's not anywhere near as good as MRI. And it's associated with so many false positives and false positive biopsies that we stopped doing it.
You did?
So yeah, we stopped doing it. It just really, I mean, I would meet women who had had 9 negative biopsies, and, you know, that just causes internal scar tissue and makes their mammograms more difficult for us to read. And so the way that it breaks down, about 10% of women have just fatty breasts, and 10% of women have extremely dense breasts. And then the rest of us are in between. 40% have something called scattered fibroglandular densities, and 40% have heterogeneously dense breasts. And so about 50% of all women have dense breasts, and 70% of women in their 30s have dense breasts. So if you have dense breasts, you should talk to your healthcare provider about your risk, because that plays into what kind of screening you might have and what might be right for you.
And are you doing, referring many patients for the fast sequence MRI? We have them in our community in Cincinnati as well. It's $395 now, I think, out of pocket to do that. Are you as happy with the results of that?
So
MRI?
Yeah, the full sequence MRI, you know, is on the order of $6,500, and it has a lot of different sequences that are taken, but the key sequence is something that we call the MIP. It's like the bottom line sequence. You know, is there something there or not something there? And that's what the fast MRI gives you, is the MIP image, and it's $250 in our area. I wish we offered it, but maybe we will in the future. And yes, I do order it a lot for women who are concerned about their density. For women who are at high risk, insurance will pay for that full sequence MRI. But unfortunately, the deductible often goes towards that as well. So you have to be careful about that.
Right. Great. Any other questions? Did I miss anything? All right, good. Well, do you have any final words, Dr. Pederson? Are you telling all your people or patients now to go back to the hospitals and get their mammograms now post-COVID, or are you telling them to wait still? What are they doing at Cleveland?
Well, Cleveland Clinic remained open this whole time for screening, interestingly enough. I have a discussion with all of my patients about whether they should go back and get their mammogram. It depends on where you live and the density of COVID in the city that you're in. And it depends on your age and your other medical problems. So if you have a BRCA1 mutation and you're young and healthy, I encourage you to go for screening. If you're 75 years old and you're a couple minutes late, I'm on the phoning. I don't encourage you to go for screening. And so, you have to be careful based on your age in terms of being exposed to this horrible virus and make sure that it's safe. Just as we in healthcare do, we wear masks. And you could wear gloves if you were so inclined. Take the gloves off when you're out of the mammogram and wash your hands. And then when you get home, throw it all in the wash and take a shower and move on with your life. But, don't go near the hospital if you're in a high density COVID area and you might, be at risk.
Well, Dr. Pederson, thank you for your generous time and your education, and we look forward to having you back again in the future. And
I'd love to come.
Thank you for all you do for women. And,
thank you too.
Thank you.
Okay.
Great. Thank you. Bye.